Greetings and welcome to this another video on Medicine Beyond Harrison series. In this infectious disease module, we'll discuss about the influenza approach for physicians. This video is completely for educational purposes. Let's get going. So, influenza, it is one of the commonest infections that as physicians we encounter on a daily basis in the influenza season that is from the start of autumn, that is in the July to December to January. There is a peak of influenza happening all around the part of India where most of the elderly get acutely ill. Some people will have acute respiratory failure, may also even lead to death. They present with acute toxic headache, myalgia, body pain, then fever, and respiratory symptoms. So we'll discuss about influenza. This is the structure of virus for your reference. So introduction, influenza is a contagious viral infection causing serious epidemics and seasonal epidemics and sporadic outbreaks. Typically presents as acute febrile illness, though it affects multiple organs. The aim is to understand challenges in treating and preventing influenza, especially in high risk groups, that is elderly, pregnancy, and with multiple comorbidities. That is why the Indian government, as well as all the many private organizations, advise influenza vaccination for elderly and with multiple comorbidities. So, what kind of a symptom profile that influenza have is categorized into systemic, which is fever, chills, weakness, and headache, of which fever is the most common presentation. It is typically noted that influenza patients present abruptly, that is on day 1 to 2 of the illness, with high-grade fever, and they will even can notice the exact time of onset of the fever. That is how the influenza fever starts abruptly. There will be chills, there will be severe weakness and headache for the patient. There'll be respiratory symptoms like at least a sore throat, dry cough, or nasal discharge, if not for shortness of breath on the initial stages. There will be eye redness in influenza, which is also a common presentation. So, virology, just a overview. There are four types, of which only A, B, and C infect humans. D does not infect the humans. Most of the epidemic is caused by types A and B worldwide. Structure is there is a hemagglutinin and neuraminidase component, of which the neuraminidase component is useful for the treatment of influenza. So circulating antigen mostly is A is H1N1 and H3N2 is the major circulating variants. So why is this influenza a very dreadful disease to create a vaccine? Because it has these components called antigenic drift and antigenic shift. Every year there occurs a antigenic drift. So that is the reason for annual vaccine updates. There will be minor frequent changes in the serotypes of the infection influenza virus. So it is an error-prone replication. That is why each year the vaccine is updated. So there will be antigenic shift once in a pandemic. That is maybe some 10 years once or 20 years once. There will be abrupt reassortments of gene segments. That is new strains. So the past Spanish flu, that is in 1918, the Asian flu in 1957, the Hong Kong flu in 1968 are all caused by this antigenic shift sequencing. So high risk groups for influenza virus is pregnant women, elderly more than 65, children less than 5, immunosuppressed and healthcare workers. In all these patients, influenza causes many major complications. Elderly patients may succumb or can have severe infections, myalgia, respiratory failure, and can get admitted. Then children less than 5 years could undergo a toxic period of illness. Immunosuppressants it can be fatal in immunosuppressed people. Healthcare workers are more exposed to influenza virus with different strains. The global burden is 3 to 5 million cases. Severe illnesses can up to 6.5 lakh respiratory deaths annually is caused by influenza virus. As of Indian data, up to 2017, there is more than a lakh tested cases, of which 7.5% is fatal. 2017 alone has contributed to around 8,000 deaths. Highest hospitalization is between the age more than 65 and age less than 5. So disease spectrum, it is usually as all viral infections will be there, there will be a viral prodrome, which is one third of the seasonal infections are just goes asymptomatic, that is only subclinical presentation. And many other types of influenza infections can present only with a mild upper respiratory tract infection. They may or may not be febrile and can resolve significantly easier. So, in comorbidities or in immunosuppressed people or in high risk groups, the influenza can present in acute fashion with viral pneumonia, acute respiratory distress syndrome, and can lead to be fatal. A significant proportion of influenza A infections are H1N1, though the exact ratio varies. The spectrum ranges from non-febrile illness to a fatal pneumonia. So clinical feature, as we described previously, if it is a patient of mild illness having only mild illness course, the onset can be having abrupt fever, that is on day 1 or 2, and it peaks on day 2 with respiratory symptoms. Cough peaks at day 2. Mostly, these mild illness patients do not require antivirals and recover without any antiviral therapy. Systemic symptoms may resolve early. Respiratory symptoms may take a week. Even after a week, the patient may have post-inflammatory cough or respiratory airway distress syndrome or reactive airway disorder syndrome. These kinds of presentation could be there where the patient can have dry cough for more than a month after a viral infection. Severe complications of influenza can occur in high-risk groups such as seizures, encephalitis, Guillain-Barré syndrome, acute myelopathy. In case of cardiac disorders, there will be myocarditis. So we have seen a lot of patients having acute LV dysfunction with influenza vaccine. There is flu positive, H1N1 positive, and their influenza IA positive, and there will be severe LV dysfunction, new onset in some 55-year-old male. That is due to myocarditis. Patient may have heart failure. It could trigger hemophagocytic lymphohistiocytosis, which can lead to high-grade fever, pancytopenia, elevated ferritin, hypofibrinogenemia, which may lead to the need of steroids. There can be myositis with acute weakness of muscles and rhabdomyolysis, which can be evidenced by elevation in creatinine. There will be urine blood. Yeah. So main differential between influenza and common cold. So not all upper respiratory tract infection is influenza. Similarly, not all upper respiratory tract infection is common cold. There is some kind of subtle differences that you can find out whether it could be influenza or it is just a common cold clinically. So influenza is acute onset, sudden and abrupt presentation within the day 1 or 2, whereas common cold takes time to evolve. It is a gradual onset. Fever is high in influenza, whereas it is low grade or rare in common cold, which is caused by rhinovirus or coronavirus. Myalgia is very prominent in influenza, whereas in common cold it is mild. Respiratory symptoms predominantly dry cough is common, whereas in common cold it is the runny or stuffy nose is common with ropey discharge. Severity, it is influenza is considered to be more severe than common cold. Recovery takes more longer, up to 1 to 2 weeks in case of influenza, whereas it is short in common cold. So diagnosis is clinical diagnosis based on symptoms and local epidemiology. You can empirically diagnose influenza and can start antiviral therapy if needed. So key predictors are the cough and fever. Laboratory methods, we can use the RT-PCR, which is the first choice. It is highly sensitive and specific. Results, you can get the results in less than 80 minutes. You can run the RT-PCR, get the results up to in 80 minutes. Detects the A and B subtypes and resistance. Most of the hospitals run these RT-PCR for influenza A, B, and RSV. So rapid molecular, it is a high accuracy method. Which it can also detect influenza in 20 to 30 minutes, which is less used commonly. Viral culture is a gold standard for typing, but takes 3 to 10 days. There are other tests which are less sensitive, such as rapid antigen test, which can predict the result in less than 30 minutes. But it is highly specific. That means if the test is positive, the patient is mostly having influenza. Immunoassays are also available, which has limited role. Non-specific lab parameters like CBC can show leukopenia. Check for electrolytes. Differential diagnosis, you can consider always rule out dengue. Other if the dengue is ruled out, then also think of Legionella. If supportive clinical findings are there, like such as hyponatremia and atypical pulmonary infiltrates with interstitial pneumonitis, and elderly with exposure to warm or air purifiers or cold conditioning systems or hospital environment previously, suspect Legionella. Other cases, you can also suspect COVID-19 and other common colds before considering influenza. So, pharmacotherapy, supportive treatment forms the overall base for the management of all patients. Hydration remains mainstay. Maintain fluid balance. You can give NSAIDs if required. Most cases resolves with just paracetamol uh, for myalgia and fever. Antiviral therapy is categorized into three types. Neuraminidase inhibitors such as Oseltamivir, Zanamivir, and Peramivir. It is the most used. And it's in India, Oseltamivir is the most commonly used drug for influenza. It is a mainstay. It blocks neuraminidase enzyme, effective against both influenza A and influenza B. Polymerase inhibitors like baloxavir, marboxil, it is not widely recommended due to high resistance. And there is also M2 inhibitors such as amantadine and rimantadine. Previously, it was used before the introduction of oseltamivir into the market. Nowadays, it is obsolete and not used due to high grade resistance. Individual antiviral drugs, mainly the four drugs that we use commonly are oseltamivir, zanamivir, peramivir, and baloxavir marboxil. So each of these drugs have different routes of administration. Where oseltamivir is oral, the commonly available brand name is Tamiflu, or other name is Antiflu. Uh, Timing, it is usually as per guidelines, it is recommended to be started within the 48 hours of onset of symptoms for maximum efficacy. But it can also be given up to fifth day of the illness. So usage in adults, children's more than 2 weeks, severe hospitalized cases. Side effects could be like there the patients usually have intractable nausea, and that some people will have vomiting and delirium after giving oseltamivir. So always prescribe an antiemetic along with oseltamivir to prevent vomiting. So zanamivir is inhaled drug, not to be used with patients having milk protein allergy. So it is also recommended to be started within 2 days, and also only recommended for patients more than 7 years of age. The side effect is bronchospasm, so avoid in asthma or COPD. Paramavir or Rapivab, it is the intravenous formulation. It is used in severe hospitalized influenza where oral or inhaled therapy cannot be useful. It is indicated only in adults more than 18 years. The side effects are diarrhea and hypertension. Meloxavir marboxil is limited evidence in India, predominantly used in abroad like UK and US. It is not currently preferred. So in this video, we have gone through the major clinical features, the diagnostic approach, and the individual treatment agents. In the next upcoming video on influenza part 2, we'll discuss about the common manifestations and the when to suspect, how many days of antiviral therapy, and what cases may require more than 5 days of antiviral therapy, and the vaccination schedule. Thank you.